So good evening. It's time for the Wednesday night 6 p.m. live event, and it's not quite 6. I went ahead and dialed in a little bit early because I had problems. The last 3 times I went live, the algorithm didn't recognize it, so it didn't pull anybody in. Ended up talking to an empty audience, and then found out there was a release problem. So wanted to make sure that it released appropriately. When we get started at 6, we're going to talk about stents, and they don't work mostly. So, oh my goodness, Gloria Blevins shared, I have 15 stents and I think it's just made me worse. Well, Gloria, I hope this, folks that have already had stents sometimes get mad when I talk about what I'm going to talk about tonight. Thank you for sharing that. Loretta Dillingham. Good morning, everyone, from the city of Brisbane in Australia. It is great to hear from you again, Loretta. Appreciate you joining. And that's right, it hit me the other day. When you join us on these, you're joining in the morning. Hello, Krista Watts. We've got just a couple more minutes before we get started. I just wanted to show the group this while we're waiting for the 6 o'clock and the start on the Stents event. Anybody recognize this? Know what it is? It's the Meridian Valley lab. It's the Kraft Insulin Survey. Someone was asking about that about 3 or 4 weeks ago, and I did commit that I was going to do an unboxing. This is not the unboxing. This is just, again, waiting for the 6 o'clock hour to get started. But yes, I do have a Kraft Insulin Survey home test box. And yes, I will do it. I just wasn't going to do it this week because it's been a very, very busy week. Let me see if I can put this over here and get started. Getting a few people here, and it's almost 6. Highway 61 filling station. Hello from Richard Line. Hello, Richard. How are you? As you can see, Richard, I think you said it was okay for me to mention your name. Richard is has been one of these guys that does some fairly high level production work. As we all know, there's nothing I do worse than production. It's and even tonight, I am going to do the shaky paper thing again because I still haven't figured out how to do a live event with the screencast or any of that. But Richard got me hooked up with the right information for the right purchase. I've actually purchased a great camera, a Canon 80D. But gosh, that thing, I never did any camera work, and that thing's driving me crazy. So Richard's teaching me that, and hopefully we'll get some huge improvements in production level. Bill Clifford, hi, I love your channel and expertise on health issues. God bless. Thank you, Bill, and God bless you as well. Loretta Dillingham, so interested and waiting for this unboxing event of the Kraft Insulin Survey. I will give you a prelim teaser. There's a lot of blood sticks. It's a paper-based blood stick, and it's called blot. Paper blot, several different names for it. And some people just don't like that because there's so much, it's a bloody process. I don't think I'm going to do mine for the group. I have to think a little bit more about, again, the production on that. So it's 6:01. Let's go ahead and get started with the topic for tonight. And for those of you that have stents already, I've had a few people react when I've done these videos on stents. This is not the first one. Actually, I did a series on them. And some people said, oh, I had a stent and it really made me feel a lot better. And I would have died had I not had the stent. There are actually times and places where stents work and work very, very well. And I'll talk about those tonight. There are times and places where stents don't appear to work very well. The science certainly indicates that they don't. And we're going to talk about some of those tonight. So here we go. This is this came from the New York Times. They covered it and actually had a great little picture. Many of you will probably recognize that. This is a heart, that's a coronary artery, and that is a stent that's been put in that artery to open it back up. Now, the headline is pretty clear, quote, unbelievable, end quote, heart stents fail to ease chest pain. So here's the thing. Anybody have any ideas how many stents are placed in the U.S. Per day? I mean, per year? Not seeing a lot of guesses yet, and it's probably too early. You haven't had the time to type it in. I believe the numbers are this, and somebody please correct me. You're able to look it up on to Google it and check. Kevin McCord already got it right. Too many. There are probably over 5 million stress tests, and stress tests don't work either for the vast majority of the time. Too many false negatives, too many false positives. Does anybody remember the whole scenario around how Tim Russert died? I'll be putting a video and some detail around that out in a few weeks. But so a little over 5 million stents, I think, and somebody please correct me. And most of which, I mean, a little over 5 million stress tests, and a little over 1 million stents. Both of which, most of them don't really work for what they were intended for. So just a couple of, to break down some ideas here. There's more than one reason for a stent. For example, heart attack treatment. You can be having a heart attack, go into the hospital with the pain, they confirm the heart attack, and a lot of those heart attacks are heart attacks that can be reversed with a stent. That is the appropriate use of a stent. There are probably about 100,000 of those that happen each year. And you remember well over 1 million stents get placed in. So what are the other reasons for placing a stent? Heart attack prevention. A huge number of them are put in there because you go in, you're wondering, why did I digress into that statement about the stress test? So here's the typical over and over and over and over again scenario. You go in, you got some sort of funny chest pain. The doc says, you know what? I don't know. Let's do a stress test because that'll tell us what's going on. Then, like I said, a whole lot of false positives on stress tests, running from symptoms to different types of dysrhythmias to some other things. And they say, you know what? Most of this stuff is okay and normal, but you got these little runs of supraventricular tachycardia or whatever, and then you're looking at the doc. The patient's looking at the doc, said, you know, so what do we do? And the doc says, well, to be sure, we probably need to do a cath. And by the way, if we find anything in there, you don't want us to do a cath, find something, and then come back out and get a consent. You need to give the consent now. We'll probably go, if we find something, we'll go ahead and do the stent. And that's the typical scenario. And that's how you end up with so many stents. So why would I say that they don't work for heart attack prevention? Well, again, it was in the New England Journal. Most of you guys that watch my channel are extremely well informed. I'm probably not telling maybe a few folks that just happen to fall into the channel, but the regular viewers, most of you know, there was a courage trial, and you know that this is the case. And I'm just listing for you the courage trial, New England Journal, several years ago. I don't remember how many. Somebody may be able to tell us. So really good evidence. And again, you look all over the country, all over the world. CDC says it. Several other people choosing wisely. These folks that are saying think twice before you get a stent, and maybe even think twice before you get a stress test. They've got your. They're not just looking out for money. They've got your welfare at heart. So what's the next indication for stents? Angina. Again, doesn't work. Now, a lot of people would argue with me on that one, at least more than might argue with me about the prevention of heart attacks. But that's actually the trial we're going to talk about tonight. ORBITA, ORBITA. That was a trial that was published in Lancet journal, I think a couple of years ago, but again, somebody can check my facts on that. We're going to, in the next couple of slides or pieces of paper, we'll talk about that ORBITA trial. So at the end, you get those indications. And a lot of times, here's the other thing. The cardiologist gets in there, the interventional guy, and sees blockage and says, you know what? I see blockage and I'm going to open it up with a stent. When you're a hammer, everything looks like a nail. I'm guilty of that. These guys are guilty of that. Who's not guilty of that? I'm not giving that as an excuse. I'm saying that's a reality. And it's a reality that we as a society have not come to grips with yet. Because again, the patient's in a very influenceable position at that point. Now, I mentioned the ORBITA trial, ORBITA, and it was, like I said, it was in the Lancet. What year was that? 2018, January of 2018. The data actually, the report started coming out late 2017, so it's about 18 months old now. And here is what is this trial is just so interesting. Number one, as the headline said, a lot of expert cardiologists said that's surprising and even unbelievable that you didn't get a positive result on chest pain. Others said that study would never have been done in the US, and I agree with them. Here's why. This was a very interesting study. Let me read this before I get to what was so interesting about this study. Symptomatic relief is the primary goal of percutaneous coronary intervention, PCI, in other words, stent, in stable angina, and is commonly observed clinically. However, there is no evidence from blinded, placebo-controlled, randomized trials to show its efficacy. Actually, that last phrase is a good segue into what is so interesting about that study. Now, think about it. What are you going to do? How are you going to do a blinded, randomized clinical trial, which, again, most of the viewers of this channel understand is the ultimate level of scientific evidence? What are you going to do? You're going to dress these people up, take them to the OR, prep them, and then not do the surgery after you've even put them to sleep? That's exactly what they did. They did a sham procedure, and they got a couple of hundred people to agree. This was not in the US. It was in England that this was done. One of the reasons that the Lancet was the journal they went to for publication. Again, I think 230 folks, and they were randomized. It was about like 109 versus 121 versus placebo and study groups. And here's what they did. They went ahead, took them in, draped them, prepped them. So from the patient's perspective, the patient had no idea whether they'd had the the stent or not. And they had already signed and knew that that could happen. Then they gave them about 6 weeks of rehab and put them back on a treadmill for a stress test. And guess what? The same number of people were cured or felt better and didn't feel better, whether they had the surgery, the stent, or not. So I know I'm going to get haters when I make comments and videos like this, but gosh, guys, I'm just reporting the news, and it's not like other docs don't know this. It's not like this hasn't hit the news. It's not like people in the know are unaware of it, but it is like, it's also not like we've responded yet. You would think when we saw that the rate of stents for angina would plummet. No. The last thing, let me just read a couple of points. The efficacy of invasive procedures can be assessed with a placebo control, as is standard for pharmacotherapy. Yes, you can, but as I said, that's a long putt. The other part of the interpretation is, in patients with medically treated angina and severe coronary stenosis, PCI or stents did not increase exercise time by more than the effect of placebo procedure or sham procedure. So again, it's there. The last comment I wanted to make is, as you might imagine, it was certainly not funded by any of the guys that make stents. That would have been a challenge too. So that's my quick story on stents not working for angina. So we've got a lot of folks here and a lot of reaction. Okay, hello from Kevin and Angela. Hello, Kevin. How are you guys doing? Good to see you. Good to hear from you. Ben FMD, as a physician myself, I would like to say thank you, Dr. Brewer, for bringing such a high level of education to the public. Thank you very much, Ben. Here's the thing. I was sitting in a Bale Duneen training session one time a few years ago, and I was thinking a lot of this stuff is fairly high level, or fairly deep in terms of the medical technology, but it's also stuff that you shouldn't have to pay $2,500 and sit in a dull hotel room for 20 hours over a weekend. You should be able to get it for free, because a lot of people are going to know, understand, and appreciate this information. And so I originally put out just a few of those prevention videos 2 years ago. They were very well received, and so we're continuing to push ahead. I was working full-time in other activities. I've been a career medical director, so I wasn't able to focus. For the first year and a half, it was like 4 hours on Saturday morning and get 4 videos out, because the algorithms was a monster in terms of needs for those couple of years. Now things may be changing, but I've retired. Quote, retired. I'm working 16 hours a day, but I'm loving it, because, as you've mentioned, this is information that needs to be made available to the public. Now, a couple of folks support me on the ugly, shaky paper production and the bad cameras and stuff like that, and I do appreciate that support as well. And I'm going to miss the shaky paper when I finally am able to get rid of that for the live events too. But a lot of people, we get a lot of hater comments on it, and I understand exactly why. You look at the other videos out there, videos that are supported by supplements and supported by other things. And again, this channel's really, it has been supported by my retirement and my full-time job earlier, but I can't do that forever. We are starting to make some income, mostly with patients, and I'm putting that back into investment for the channel. Speaking of which, I don't want to get too financial tonight, but I will say we've already had a couple of folks sign up for Patreon. Greatly appreciate it. Again, that's what this is all about: helping others understand the drivers of death and disability, and where we can intervene, and where they can intervene with their own drivers. So Kevin and Brenner, Kevel had a few comments. How many stents are done? Too many. In the millions. Ha. Heart attack. Stress test is the worst. Lack of history. Gloria Blevins, an EKG and a stress test doesn't find that I have any blockages, but then they do an angiogram and I'm almost 100% blocked. Yeah. Well, I have to stop for a second. This is another point about the history and what's going on with the channel. You guys may not know this, but Todd Eldridge, who's come on with me a few times and presented about the CIMT, Todd is an official Amazon bestseller. He put out a book on CIMT, and that book was the bestseller on Amazon out of all books for a day. So now he's got a big plaque, and don't tell him I said for a day, but anyway, my point was that information is really good, but Todd, you wrote it for doctors. I'd like to rewrite it and write it for people, for patients. And that's what we're doing right now. Why did I segue into that? Because you're talking about an EKG and a stress test not finding plaque and then going straight to an angiogram. That's exactly what the first part of the book is. It's looking at the ways to measure plaque. What's the number one killer? Well, heart attack. What's the number one disabler? Stroke. What causes both of them? The same thing: plaque, cardiovascular inflammation. Now, if you've got plaque, that's very important to know, right? So how do you find out if you got plaque? Well, you go to your doc, and what's the doc do? Well, I don't know. Let's do a stress test. And there we go again. Well, oops, you got something on the stress test here, and here's what I think we should do. I think we should get an angiogram. So again, that's where you go. Now, they're skipping a couple of steps. Number one, I've already talked about stress tests, but what are some better steps? Believe it or not, there's a do-it-yourself, a DIY, and I cover that in the book. I've got a video on it. It's not going to come out for a couple of months. It's called ABI, ankle brachial index. What you do is you get blood pressure, well, not in your wrist, blood pressure here in your arm and in your ankle. You get it 3 times, and the blood pressure in your ankle should be at least as high as your arm. Should be maybe 1.4 times, 40% higher. But as long as it's at least as high or higher, that's a good number. If you've got a lot of plaque down in your aorta and your arteries between the heart and the iliac arteries, things like that. If you've got a lot of plaque in there, that will slow that down and lower your blood pressure. So it's not good news if you do one of these ABIs and your ankle blood pressure is less than your arm blood pressure. Now, is that a perfect test? No, it's not a perfect test. Most people would say you've got to do it with a Doppler. You really don't have to. There's actually research that's been done which demonstrates that you can do an ABI with a plain old Omron. And I did an ABI on me with an Omron and showed the pictures, and that'll be in the video in a couple of months. Is that perfect? No. And in fact, you can have, in one study, they looked and they found that patients that had really bad plaque with a lot of calcium and significant problems, in fact, headed towards amputation, a lot of those patients also had higher blood pressure in their legs. So, you know what? It's always something. the reality is, you're not going to be one of those patients. I know that I'm not. I do, I run on my high intensity intervals twice a week. I'll run, they're 1 minute intervals, they're short, but it's up an incline and it's a 10 mile per hour pace or a 6 minute mile pace. You can't do that if you've got so much plaque in there that you're at risk for an amputation. Maybe I jumped through too many things real quick, but bottom line is, yes, there's a DIY way of checking for plaque. It's not that good. It's got problems, but they all do. It's got a major advantage in that you can get an Omron. It's $35 on Amazon. So what's the next best way to get a screen? Well, there are two next best ways. One of them is coronary calcium score, and the other one is CIMT. That's why I was talking about Todd. And again, I'm giving you a little bit of background on my part of the book. I'll be writing the first half of this book on exactly what we're talking about, how to measure plaque, because as important as it is, it's the biggest killer, biggest disabler, we still use something like a stress test to look for it. And there are better ways. And the only way I think that we're going to change bad practices is to educate, even patients, where patients can come in and say, look, I saw this doc on YouTube and he may have been crazy, but he mentioned CIMT and a calcium score. Why are we not doing one of those? So here's the advantages of a calcium score. It's easy, it's objective, it costs about $70. Both of them, CIMT costs anywhere between $70 and $150, depending on how much travel there is involved. Another advantage of calcium score is that you can get these almost anywhere. They are ubiquitous. What are the disadvantages of a calcium score? Well, a couple of things. Number one, it's not that sensitive. You can measure progress year by year with ultrasound. With CIMT. You can't measure progress year by year significantly with calcium. In fact, people recommend that you get maybe two, once every 5 to 10 years. And there are really like 3, maybe 4 levels of gradation in a calcium score. So it's a good screen. It's not at all good for following up to see, okay, I've lost 30 pounds. I've changed my diet. I've done a lot of good things in my lifestyle. What's happening to my plaque? You're not going to really get that from calcium score. I know John did a video where he did show a difference. That was remarkable. I've seen that in 2, maybe 4 patients total in my life. You don't see that a lot. So it's not good for following that. It also can totally miss plaque entirely because it's measuring calcium. It's not measuring plaque. If you have plaque in your coronary arteries and it's all soft, then you're not going to see anything on the calcium scan. Has that ever happened? Actually, I've seen a patient where that was, we ended up proving that that's exactly what was going on. So that's the advantages of a calcium score and disadvantages. I know a lot of you watch Ivor Cummins. I'm a major fan of Ivor Cummins. He and I are sort of like complementary twins or whatever. He's focused more on the calcium score. He's got a wealthy patron whose life was very likely saved by getting a calcium score. He does acknowledge, and he does have a couple of videos on CIMT. I'm a major fan of CIMT, and I do occasionally use calcium score. Why am I more of a fan of a CIMT? Because I've got good access to a good quality one. What's the major problem with CIMT? It's variable. It's very dependent on the ability of the tech to get the right view and then do the right reading. Now, again, Todd's got that's his sweet spot. He's got a doctorate in epidemiology focused on medical quality, medical technology quality. So he's really good at that. He does provide that service, CIMT, to my patients around the country. I'm trying to push him to go to Australia, and we'll see. I think that's not that close. But I will say one other thing. Well, I haven't talked about the advantages. Remind me to talk about the CIMT tour if I forget. I didn't talk about the advantages of a CIMT. The CIMT, like I said, I mentioned a minute ago, I follow patients every year, and we can see changes in their CIMT based on how good they're doing in terms of their lifestyle and the other things that we're doing to intervene with their plaque deposition. And in some cases, plaque reversal. So that's advantage number one. I didn't mention the disadvantage of radiation and radiation safety with the calcium score. And here's the reason. A lot of people say, well, Ford, that's a CT, it's a scan. It's what, is it 10 millijoules, 2 to 10 millijoules? Bottom line, it's between 10 and 100 chest x-rays. And the bottom line on that is, what does that really mean? If you subject a newborn infant to 10 millijoules, I think the number is, that gives them like a 1 to 2% chance of developing a cancer over their lifetime. If people say, well, that's bad, that's dangerous. Think about it. If you find plaque, if you're somebody like me who is otherwise low risk, and there's a lot of us out there, low risk by history and blood work and everything else, but we find plaque, and your risk of heart attack goes from 5% or less to 40% with that one. We've got either of these studies, the calcium score or the CIMT, automatically go from less than 5 to 40% or more probability of having an event, not over our lifetime, but over the next 10 years. So as you can see, those the risk that you're finding, you're demonstrating, identifying, just is not in the same ballpark as this 1% for an infant for an entire lifetime. Totally different. And so it's well worth it. Why did I get into that level of detail? Here's why. You won't ever see calcium score being done on infants 5 years old, 10-year-old, 20-year-old, stuff like that, because there is significant some significant radiation there. Well, how is that an advantage? And could you do that with CIMT? The answer is yes, of course you can do that with CIMT. That's why we have nomograms, which show the average amount of LDL that's been deposited in the artery wall by age, starting all the way down at 0, and documenting infants that are newborn, all the way up to 80 years old. So, and that's actually how you come up with this concept or thought of, quote, arterial age. So, yes, there are advantages and disadvantages. Bottom line, I don't do as many. I've got great access to a CIMT, so I'll focus on those. I've done maybe half a dozen calcium scores. But here's my bottom line. And it goes back to what we were talking about in the beginning. Either one, get either one before you get a stress test, and then go from the stress test, get a false positive, and then go into the cath lab, and we know where that's going next. So I hope that's been helpful in terms of discussions about how to find plaque and what to do. Well, we didn't talk much about what to do about it tonight. Thank you for listening or for your interest. Now let's go back to some comments. No stent should, Brenner, no stent should ever be used. Evaluation is off. CHA. Not sure what CHA means. Eva Maria B, no closed caption now. Please let me know when it is. Oh, Eva, what we do, these are published, these remain open to the public after the event itself. So if you're not able to speak English, or if you do speak English but don't understand my Southern version of it, yes, give us a week or two and it will be into closed caption. Loretta Dillingham, stents are said not to work for prevention because they too become blocked. Nathan Petty, you can get a stress test in thousands of locations. Try finding a CIMT. Try finding a Kraft insulin survey. We're upside down. Bingo. I couldn't agree more, Nathan. And that's why I'm a crazy man yelling on YouTube. I don't know if you saw this, Nathan, about the Kraft insulin survey. I'm going to do an unboxing on this Wednesday night event. Somebody requested it. This is the Kraft insulin survey. So one distinction I would make is, you're right. You can't just walk into a LabCorp or a Quest and get a Kraft insulin survey, but you can get it at home, and that's what we're going to do. I get these for my patients all over the country, and we get them at home. Like I had said before the meeting started, it gets a little bit messy, but it's certainly worth it. You've seen John's video where he talked about at the end, I think one of his last numbers was close to 300. Even if you looked at his OGTT, which most docs don't look at, it looked fairly normal up until, and then it was hours 2 and 3 that it went off the reservation. If you look at Joe Kraft in his book, he shows you how that just happens, and I've seen it more than once where patients are able to handle that glucose challenge in the beginning, and that's probably stored insulin in their pancreas, but they have a challenge making enough to respond, and then so after like hour 2, it just starts cranking right up. Okay, Brenner Cavill, but patients don't have a choice. That is, that's exactly right, and that's, I don't know what else to do and where else to start other than educating patients so they can start pushing back. If patients start pushing back, they can make changes. For example, go back to the HMO days. Patients, HMOs in many ways, don't throw rocks. In many ways, HMOs did work. But patients still made major changes and actually deep sixed a lot of HMOs just because they reacted over and over and over. We can do that too. We can start saying, guys, why are we always getting stents? Why are we always getting treadmills? And why are we not getting CIMT? Speaking of why are we not getting CIMT? So if you haven't seen any of our videos where we did the CIMT tour, please go look. Google Ford Brewer CIMT Access Tour, and it should pop up, and it'll show you a place where you can click. We're going to do a tour around the country, large cities, and we'll start making that more available. We were just talking about that a couple of days ago. LA's probably going to get one. Cincinnati's probably going to get one because it's an hour from me. Orlando's probably going to get one. Someplace in Texas for sure is going to get one. And then we're going to start, after we get that experience, then we're going to start seeing how can we make it available to smaller and smaller cities. Loretta, I think, aren't you in Australia? Yeah. My next big goal is, how are we going to get one into Australia? So please go there, click on it, and then request your city, because that's how we're planning our that access tour. The most requests for a city, that city wins. And it's not just going to be one city, it's going to be a tour. Oh, Brenner Cavell, OGTT. I'm sorry, oral glucose tolerance test. Another bad practice in medicine today, something that needs to be improved, is that there are basically two ways that docs tend to look at and diagnose prediabetes, which is the major driver for most of this. Prediabetes or even full-blown diabetes. They look to see your fasting glucose, and then they look to see if what your hemoglobin A1C is. Hemoglobin A1C can typically be 20% off, 15% off. So if you've got a hemoglobin A1C of 5, 15% of that's going to be what? 0.75. So the real number, if you've got a 5, you could be doing really good at 5. You could be doing Superman level at 4.25, or you could actually be not so good at 5.75. So hemoglobin A1C, even though it's very popular, is not a good screening tool for diabetes. That's what it's being used for because, again, it's easy, it's simple, it's a number, and it's the science. So what's the best way? OGTT, oral glucose tolerance test. So the patient fasts for 8 hours, then we give them 75 grams of glucose, and then we measure the blood sugar before we give them the glucose, 1 hour afterwards, and 2 hours afterwards. We've actually been able, speaking of the access to the Kraft Insulin Survey, we've been negotiating with Quest for a long time. They finally agreed to create a little bit more of an insulin survey out of the OGTT that they do with us. What does that mean? At the 0, 1, and 2 hour time periods, if we can get them to, they'll actually draw an insulin level as well. Why is that important? Because there's at least two different things, totally different things that drive blood sugar level. One is your cells and how responsive they are to insulin. And two, how much insulin you're putting out. So for example, I had a patient that had last week, had a 0 fasting, like a 170, 1 hour, and a 130, 2 hours, which is bad. It's clearly, but it's not terrible until you looked at his insulin numbers. The first number was like 15. We want a fasting below 5. The second number was over 100. You never want insulin to be getting over 50. His was over 100 at the time that his blood, and that was just to keep his blood sugar at 175. When it got down to 130, it was, what was it, like 60. So that's why it's nice to be able to get insulin as well as those other numbers. While we're talking about all this sugar business, again, those of you that get sick of hearing about that, I get sick of talking about it, but that's what drives death and disability. Death and disability. I'm maybe talking a little too fast. There is a new method that's out there. It's not totally new. We've had continuous glucose monitoring forever. And I do end up doing this on almost every one of these events. There's continuous glucose monitoring that's like $70 now. It's here. Now I think, dang, Richard, you told me how to avoid all this light reflection, and I don't remember what to do. Anyhow, there's a little app, and it's called Libre Link Freestyle, and that's where I'm watching my blood sugar. You tap it right here, and uh-oh, my sensor ended. I knew I was getting close. My sensor ended, but I'll show you. You can see that green is between 80 and 150. I was fasting a couple of days ago, and here's what you saw. between midnight and noon the next day, my blood sugar was down in that red level. And that red level, as you can see, about 3 in the morning, it was hitting like 50. I felt great that next day. And that's usually the pattern that I see when I'm fasting. So you could say blood sugar, one of the things we have assumed until this thing came out was that blood sugar values were stable. And I can tell you, when I broke my fast last night, I had pizza and a glass of wine with my son. I didn't eat any of the pasta. I just ate the cheese off the top and had a Cabernet, not a sweet wine. My blood sugar, when I woke up this morning at 7 o'clock, went up to 125. Now, that's one of the definitions. A fasting blood sugar of 125 is one of the definitions of full-blown diabetes. What's happening now that we've got such good access, such good access to continuous glucose monitoring, the research is starting to come out of the woodwork where it's showing that all these things we thought about stability of blood sugar and the levels that it should be, those are getting challenged. And it's a good thing because we're learning a whole lot about a very important thing for our health. Loretta, Brisbane instead of Sydney or Melbourne. Got it. If we can, when we get to Australia, the first city is going to be Brisbane. And I don't think I told you. Pardon me, I got to just digress. I know that my whole life is a digression, but I got to digress. I was almost in a member of the equivalent of the National Institutes of Health in Australia. Now that sounds weird, but check my facts on this. When I was at Hopkins, a guy came up from Australia and he toured around and met with a lot of us, and he said, "Here's my goal. I've been told that I need to recruit a bunch of guys to come down and be in our version of the NIH." And I thought, and he invited me. He gave me a job offer right there on the spot, and I was so excited. I couldn't think of anything more exciting than moving to Australia. Now, again, this wasn't 2 years ago. It wasn't 5 years ago. It was 30 years ago. So I went home. I was so excited. I told Janice. She panicked. I gave up on that idea. And you know what? She's regretted it ever since. Richard, I'm going to call to you. It looks like I've gotten really blurry. Guys, I don't really know what to do. Sorry. Hopefully it'll, maybe starting to come back. We're going to clean this production up. Vidal Chloride, thank you very much. May God reward you. Thank you as well. Stephen Horst, could you do the test in Oregon or Seattle? Please keep the Northwest in mind. Absolutely. Actually, Todd did one in Sacramento a couple of years ago. He had like 500 people. He ended up having a CIMT tech going back to Sacramento for weeks to get that all completed. Peter Liness. Peter, how are you doing? And it's New Zealand, right? If you already know you have plaque and insulin resistance, is there any benefit in doing the Kraft insulin survey? Yes, a couple of things. Number one, it helps you understand your glucose pattern. Number two, it's like doing an OGTT every year. For people that are not full-blown diabetic, I do recommend that you just check it every year to get, again, an understanding of your pattern. Now, that may sound kind of nebulous, but here's the thing. Obviously, maybe you could click on here, the numbers. How many people know? Click yes. Know that you have insulin resistance or diabetes. Once you find that out, life changes because it's not a simple, I take a pill for this and that's the end. It just changes everything. Okay, here we go. Yes, yes, yes. Um, and yeah, correct me if you think that, or debate that with me if you think that's wrong. To properly manage diabetes, you got to learn a lot of stuff, and you got to change a lot of stuff from the way you sleep to how you eat, to how you eat, to how you eat, to the way you exercise, the timing on when you do these things, etc. And guess what? If you wait till you've got full-blown diabetes, it's way too late. Uh, it's not too late. It's never too late. But one of the major goals in one of my major legacy goals is to get people to understand this a lot earlier and start making those changes. And so back to your question, Peter, yes, the more you can know about exactly how your pancreas and beta cells tend to react, whether you're a slow reactor, fast reactor, is this just appear to be more of a basal cortisol thing? All of those things are things that are helpful to know. Joe Beam, Libre is not accurate enough. Joe, you're not the only person that thinks that. There's a lot of people that do. In fact, I have several patients who've tried it and they said, oh, that's no good. And in fact, you know, John on this channel tried it. John is he got some very interesting information about it, but he was in high-tech engineering and didn't like the numbers, the accuracy numbers. People think, well, you know what? I want to get a, you know, at least maybe I can't get the accuracy of a reference lab like LabCorp or Quest, but I at least want to get within 10 points. Think about what I just said. That is assuming that Quest and LabCorp are always going to be within 10 points. Then any of you who've had a lab panel with me, and this is one of the exercises we usually do at our boot camps. We've got one coming up in Louisville in November. We'll get everybody to look at their, you actually have two different fasting blood sugars from Quest when you bring those labs to the table. One is just the fasting blood sugar that's associated with the metabolic panel. The other one is the fasting blood sugar that's associated with the OGTT. Those are typically off by a factor of 10. Not unusual at all. And that's a big number. It's very significant. That's between 85 and 95. Huge difference. And so you say, well, I want it within a factor of 10. You're not getting it within a factor of 10 with LabCorp and Quest. I mean, not always. So I understand Libre's got accuracy problems, but it does tell you patterns, and that's what you need to know. You need to know, for example, how does my blood sugar do when I eat beans? Some people get huge increase, some people don't. How about legumes? Some people do fine with beans, but then they go out the roof with legumes. How about different types of nuts? You know, again, same kind of thing. And unless you start watching that, you're not going to know. Again, I can see I'm blurring up again. So let me give you another example. You remember when I showed you, you can say, well, I'm going to do a lot of fasting blood glucose. I don't need to do, I mean, I'm going to do a lot of finger stick blood glucose. I don't need to do that. Okay, that's fine. Are you going to do them every night between midnight and 6 a.m.? Not very many of us will. So again, that's my point. You get a lot, you learn a lot about, and if your blood sugar's 50 between midnight and 6 a.m., that's something important to know. A lot of people think that's bad. It's not really bad. It's actually not bad. It's good. It's better than it being 90 and 100 from midnight to or 100. It's clearly better than it being 90 to 120 from midnight to 6 a.m. And how are you going to know that? By doing finger sticks. Okay. Richard Lund, here you are clear. Yep, I'm clear, and then I'm fogging up. Well, that's, sort of my life. You may have had an internet speed problem. Yep, that might be true too. Joe ARI, Joe, how you doing? Good to see you. Thanks for joining. Vidal Charid, what do I think of keto? I think keto is, it's very interesting. Back in the days, it's been around long before another senior moment. The guy that Scarsdale diet, the guy that got shot, a cardiologist, Atkins. It was around long before Atkins, but Atkins really popularized it back in the 70s, 80s time period. During that time, many people thought the keto diet was unhealthy. They thought it would mess up your lipids. They thought there was no telling what it could do. Probably make you cause a lot more plaque, kill you early, et cetera, et cetera, et cetera. I was one of those people that was not so sure about the safety and the efficacy of the keto diet. Well, that has changed. When he died, he was a very wealthy man, Atkins, and he left a lot of money to do some of the best clinical trials on diets that have been done to date. And a lot of those clinical trials demonstrated that, yeah, you may get some unusual numbers in the beginning, but most of us don't in terms of our lipids. We're also finding that maybe it's not all LDL. I'm being facetious. We know it's not all LDL, and again, I don't want to open that can of worms quite yet. Bottom line is, I do think keto is a good diet. Now, then there's, I could go off in another tangent on what do you really mean by keto. Ketosis, anytime you burn fat, a fat molecule is a triglyceride. So you've got 3 fatty acids that are hooked together by a glycerin molecule. And you may recognize glycerin. Glycerin is actually a sweetener. It's been used as a sweetener before. And if you go back to the old Prolon diet, that's one of their little secret weapons, is they have glycerin that you sweeten things with, and you sip on that glycerin all day. It keeps you from bonking, but we can all assume it's fairly innocuous, because as you're fasting, you're burning triglycerides, which means you're breaking these off, burning them. You're going to have glycerin there, and these things these fatty acids, when you break them off, you burn them down to ketones. So as long as you're losing weight, you're creating ketones. Now, most people, when they talk about the keto diet, they're talking about just porking out on bacon all the time. And I actually was like plant-based for about 30 years. As I started working more and more with insulin resistance and got insulin resistance myself, I started backing away from plant-based. Bottom line is, you can be keto on plant-based, you can be keto on bacon. I can't go here without going to that final item. We all want to debate what's the best diet, because we all assume that the best diet for me is also the best diet for you. That's also the best diet for everybody. I don't believe that, but I will say this: I grew up in preventive medicine, so I originally believed mostly in the plant-based diet. If you get over the carb thing and realize, some of the challenges in eating plant-based and carbs for people that have insulin resistance, then that's one thing. But then, one of the major planks left in the vegan diet world is, or vegan diet platform, is TMAO. Well, I studied TMAO, and I really am skeptical that TMAO is the risk that a lot of people think it is. TMAO, trimethylamine oxide. And that's a long story. If you have a question about that, just look up my name and TMAO. I've got 2 or 3 videos on that. Little Viking coach, cover lens with hand to refocus the lens. Great suggestion. Thank you, little Viking. Joe, pattern. How many hours a day does your blood sugar stay way high? Freestyle. It really depends on whether it depends on what I'm doing. I keep an eye on it, and I usually know what's going to make it spike. For example, if you may remember one of my first YouTube live events, I was doing a Proline event because I wanted to get people aware. You know, people don't like fasting, and you know why? It's very uncomfortable the first time you do it, and we're 60 years. So many of us are 60 years old, and our bodies have been used to eating 4 times a day, and so we go for 24 hours, and it's hard. Yet there is very significant biochemical and medical evidence, research evidence that is good for us. So one of the things I wanted to do is Proline is like the easy button for learning to fast. It takes you down to about first day is like 1,100 calories. Days 2 through 5 are like 700 or 800 calories. And you get these 2 little meals. So I was doing that event, Joe, and what happened was I had not done one of those with a freestyle, with one of these at the time. So there's 2 meals. Both of them are soups. They're both of them, because of the problems that proteins tend to cause in terms of inflammatory markers. These things are way low on protein. So if they're more plant-based, lower fat, way low on protein, there's only one thing he's got left, and that's carbohydrates. And these were processed carbohydrates. There may be healthy carbohydrates, but they're processed, meaning they're powdered. So when I would eat these 2, they would spike my blood sugar up to 180. And it was after I saw that, I'd go out, I'd take a walk right after eating, and sure enough, I'd cut the head right off of that spike. So I just share that detail because that helps you begin to understand, okay, I can't remember who it was that was hating on the hating on the Libre. Again, it doesn't matter if it's 10 off up or down, when what you're looking for is to see what makes it spike. And you get a surprise like I got with Proline, and you know, okay, I need to go out and take a walk. Here's an issue. I inherited some pretty bad allergies from my mom. I know I could use a speaking coach, and I'm on ACE inhibitors, Ramipril. All three of those things make me sometimes clear my throat a lot. I've actually had folks complain that he's very impolite. He's clearing his throat a lot, and he's not apologizing. If I apologize every time I cleared my throat, it would be a YouTube channel of throat clearing. Thank you for your patience. It's 7 o'clock. We've still got a lot of activity, and I don't have a lot of. I got some stuff I need to do, but let's go on a little bit further. Hello, no stents yet. Alien on a bike. Good to hear from you. Kevin McCord. The goal of any diet is reducing insulin resistance and cardiovascular inflammation. From Angela. Yes, Kevin is a physician with an interest in this space, and Angela, Kevin has done the Bale-Donine activity, so he's got a lot of background and understanding. And Angela is getting some, is also in the medical field, has a training and experience in managing healthcare, and is doing a lot of work in terms of training and diet. Going to be doing some work with us, hopefully, in terms of our patients and helping get our patients a little bit more educated and knowledgeable regarding insulin resistance and the importance of diet. Loretta Dillingham, good to hear you mention TMAO. Well, Loretta, it's good to hear that you recognize it and you understand the importance. Paul Gagne, I hope I pronounced that right. Fasting gets easier as carbs go down. I'm glad you brought that up. That's a very good point. Since the vast majority of my patients are coming to me from the YouTube channel now, Over half of my patients, new patients, come to me and have already lost 30 pounds or more. It's very, very interesting. It's like the dream patient population. And they know a lot of the stuff that we're talking about. And I say, you know, I had a couple of them recently that had lost 80 pounds. And I said, you've done so much. Your numbers are looking great. You've got some plaque now, but that was clearly old plaque, et cetera, et cetera, et cetera. And they all say the same thing. Yeah, and I'm here to dial it in even further. So great kind of patient to have. The reason I brought all that up is this. Almost all of them are losing the weight the same way. First, they stop the carbs. Once you stop the carbs, this blood sugar of doing this tends to slow down and it starts to stabilize. Once that happens, then the hunger doesn't happen as much. And then they start closing that eating window from 6 a.m. to 10 p.m. down up to about 11 or noon to 6 p.m. So they just reverse it. Instead of eating 16, 18 hours a day, they're only eating 6 hours a day. And those are the two things that really make a difference. So with those patients, usually I will say, okay, well, then the next thing is some type of fasting. And fasting is, I don't get a lot of takers on that. Booster C, Dr. Boz and Two Fit Docs, Dr. Finney. I'm a big fan of Dr. Boz. I've seen a few of Two Fit Docs. I'm a fan as well. Dr. Finney, I don't know. Espinay, thank you, Doctor. Tony Caballero, thank you, Booster C. Little Viking, have you heard of the nitric oxide supplement Neo 40? I've heard of several nitric oxide supplements. Citrulline is actually one of them, arginine. I haven't heard of Neo 40, but I'd be surprised if it didn't have at least one of those in it. Perfect pronunciation. Paul Gagne, perfect pronunciation. Good. I took French when I was in high school. I lost about 30 listening to you and a couple of other people. Nina Tycholz. I've heard of Nina. Is she the lady with the TED Talk? Maybe not. But you know what? So it's Paul Gagne saying, I lost 30 pounds, listening to you and a couple of other people. I can't tell you how many times I've heard that, and it's like, makes my day, makes my year, makes all of that work, the 16 hours a day doing this, worthwhile. Because Paul, you lose 30 pounds, and barring cancer or a trauma, a car wreck, flight, airline crash, something like that, you've very probably bought yourself at least a decade, maybe 3, of healthy life. So that's a life-changing event. Losing 30 pounds, there's no medication at all that can compare to that kind of lifestyle change in terms of impact. Peter Linnes, great show today. Thanks. Thank you for your input, Peter. Richard Morris, if stress can increase blood glucose levels, can a beta blocker propranolol decrease it? Actually, some of the beta blockers actually increase. Metoprolol actually goes the way. It actually tends to increase insulin resistance. It is Nathan Petty asked about craft unboxing. Nathan, I thought you were here earlier. I do have it. And I just did a little peek, a little tease, but I am still, we've done this a couple of times tonight. I'm going to do a full unboxing. And again, I'm trying to decide whether I'm going to do the finger sticks and all of that bloody stuff. I don't think we want me to do that. It's hard enough to manage the discussion. Tony Caballero, thank you, Loretta. Ken Patu, good to hear from you. At age 46, I got a CAC score over 1,000. Went down the stress test, PCI road, had 2 artery. Ken Patu, if you're not a medical person, you're the first person that I know that uses the term PCI. Maybe it's because you've had them. You know the drill. Had 2 arteries blocked, 95%. Got 3 stents. We'll never know if I made the right choice, but feeling great. Athletic, BMI 22. It's a great, you're doing great work in terms of remaining athletic and having a BMI of 22. And you're exactly right. That's one of the reasons that this practice hasn't changed that much, even though the science would indicate what I showed earlier tonight. How do you know that it didn't work after it was done? We're continue to have a lot of interest. Guys, I do have to go. It's 7:07. We've been going for about an hour and 10, 15 minutes. Thank you so much for your interest, and I'm going to sign out. If I can figure out how to do it. Ah, gosh, I was off on vacation and I had these. Here we go. Thanks again.